is a fellow of the Philippine College of Physicians and a fellow also of the Philippine College of Chest Physicians. She will be talking about the effects of the effect of COVID-19 on the management of asthma. So without further ado, may I introduce to you Dr. Cynthia Talla to for to talk about the management of asthma in the COVID-19 pandemic. Doctora?
Alam mo, my video is not working, so you cannot see me. I don't know why. If you cannot see me, I'll just put my profile there. It doesn't work. I don't know why. Anyway, so I'll just share with you my slides, please. Again, share screen. And then, can you stop your screen sharing first? Because I cannot get in. You're done?
Yes, Doctora.
Okay. So share screen. Can you see?
Ayan na po, Doctora.
Tara na. Is it on the view mode?
Yes.
Yes. Okay. So, good afternoon. When I was asked by Dr. Gelido to give a lecture on asthma, actually I readily said yes, no, because I know that now is asthma season, and this lecture is very timely, especially for those who are suffering from asthma or to doctors who are actually managing asthma patients, no. So this is my disclosure, and how I would like to go about the discussion is I um, divided it into two parts. First, mainly, I will try to present to you the GINA 2020 guideline. And this is important because there's really a paradigm shift right now, no? And then give you the Philippine Consensus Report on Asthma Diagnosis and Management 2020 also. And we will differentiate it from the GINA 2020. But before I do that, of course, I have to give you also the evidences that drove the changing concepts in the management of asthma, and give you a little background on the burden of asthma and pathophysiology before we go to the impact of COVID-19 on asthma. So there's really an unmet need in asthma care. Okay, in our area, there are a lot of people suffering from asthma. But unfortunately, the Philippines ranks number 2 worldwide as far as asthma mortality is concerned. Now, let me try to walk you through memory lane. In the early part of the century, we have regarded asthma as just a disease of bronchoconstriction. So most of the medicines then really actually centered on how to bronchodilate by the use of short-acting bronchodilators. And it's only in the 1980s when inflammation was regarded as the pathophysiology underlying asthmatic patients, and inhaled corticosteroid benefit in it, no? That's why it later became the gold standard in the treatment. It was only in the 1990s when the LABA came in the picture, but it is separate from the inhaled corticosteroids. Now, the GINA, or the Global Initiative for Asthma, actually was conceptualized in 1993, but the first guideline came out in 1995. And then in the 2000s, that is when the combination of the ICS LABA came in, and then until now we have it. Okay, let me just try to use the laser pointer. Okay. So asthma is a chronic inflammatory disease, okay? And inflammation is actually central to the development of asthma symptoms and exacerbations. To your left is a normal airway, okay? And then beside it is how an asthmatic airway would look like. It's filled with inflammatory cells, you have mucus hypersecretion, and you have smooth muscle thickening all leading to the bronchoconstriction that we have in asthma. Now, when we talk about asthma control, we don't like to control only the symptoms, okay? But symptom control is actually defined also as few asthma symptoms. There shouldn't be any sleep disturbance, no exercise limitation, but we should also reduce the risk, okay? Risk reduction is actually defined also as maintaining normal lung function, prevent flare-ups or exacerbations, preventing asthma death, and of course, avoiding side effects. Unfortunately, patients' goals may be different from ours. Okay. To the patient, when they get to puff their quick relief inhaler, they're good. Okay. It's just like magic to them. When they have symptoms and they puff the quick relief medication, they thought they're doing okay. Okay. But they are using it several times a day or several times a week. See, to them, that's okay. To them, that's already controlled. And patients may have different goals compared with the doctors, no? And to us, symptoms and risk may be also discordant, and we have to assess for both. Now, these are the things that you have to ask your asthma patients, no? When you want to see how controlled their symptom is. So there are four. One is daytime symptoms, and the magic number is 2. Okay, there shouldn't be any daytime symptoms twice more than twice a week. Okay, and of course, if they have the symptoms, they will be using the reliever. So if there shouldn't be any SABA reliever use more than 2 times a week. Third is there shouldn't be nighttime awakening because of asthma. And fourth, there shouldn't be any limitation of activity because of asthma. So when your answer to that is none, then you have well-controlled symptoms. 1 to 2, partly controlled, and 3 to 4 is uncontrolled. So you have to ask that for the past month, okay? And then you will get your answer. Now, what is the real situation actually? So this is a study that looked at asthma insights and reality in our area and across all severities. So here you can see mild intermittent asthmatics there, the mild persistent, the moderate, and the severe persistent. And here are some of the medications that they are using. Supposedly, if you are a persistent asthmatic, the asthma should be controlled, diba? But here you can see that the use of the controller medications to control the asthma is very, very low. And what are they using? They are using their quick relief medicines. And the quick relief medicines that we know is salbutamol, terbutaline, phenytoterol. Okay, here you can see the average use is around 58%. So it's not good. All the while they thought they're doing okay every time they puff it. Now, this is actually translated into the risk of exacerbations. So SABA overuse, here it's defined as more than 3 canisters or more in a year. That's something like 1 to 2 puffs in a day. And these patients are associated to have a twofold increase in ER visits or being hospitalized, whether we are dealing with adults or even children. Now, the SABA-only users had not only poor asthma control, but they are the ones also using the urgent health care, be it an urgent GP visit or doctor visit to the ER, or being hospitalized. Now, this is also translated into mortality. Okay, the graph to your left is if those patients use 1 or more canisters per year, then there is an exponential increase in mortality. On the other hand, those using the controller medication, especially the inhaled corticosteroids, the more inhalers they use, the inhaled corticosteroids, the better the survival. The mortality is decreased by 21%. Now, what's interesting is even the mild asthmatics, intermittent ones, okay? Ito yung mga hindi masyadong sinusumpo, are at the same risk of dying as the severe persistent asthmatics. So there must really be a problem, no? Maybe the asthma experts are actually thinking, hey, we're doing something wrong here, okay? So maybe we are mishandling our patients, no? Especially the mild asthmatic ones. And if we look at the 2018 guideline of the GINA, which is actually revised every year, take a look. Okay, the reliever recommendation there is just a SABA. Okay, and for the preferred controller, none. And controller actually is defined as something, a medication that will decrease exacerbation and decreasing future risk. So there's none there. Okay. So they thought there must be something that needed to be done because after all our asthmatic patients, whether they are symptomatic or not, whether they are mild, moderate, or persistent, airway inflammation is always present. Now, here is a graph that tells you that airway inflammation is always there. Now, once in a lifetime, a patient may have an exacerbation, okay? The red one, okay? In an exacerbation, inflammation gets worse. And even before it gets to its peak, patients will be manifesting increasing symptoms, and they would know that. And if there's increasing symptoms, they will use their puff more. Okay, so they are empowered to do something to relieve their dyspnea. What they don't know is aside from the increasing symptoms, there is worsening inflammation. Okay, so maybe the anti-inflammatory reliever strategy is actually introduced to cover this. Okay, so whenever you have an exacerbation with increasing symptoms and worsening inflammation, actually stop, okay, the progression of the exacerbation getting to its worst. Now, GINA knows that, no? The GINA experts or the asthma experts know that there is poor adherence to these controller medications. And the poor adherence is actually a modifiable risk factor for exacerbations. So at the time, since 2007, they have been actively looking for interventions for mild asthma, precisely to prevent the risk of asthma-related exacerbations and death. And lo and behold, in 2014, Astra actually gave the funding to sponsor the RCTs and made a study, randomized controlled trial study on the as needed ICS-formoterol for risk reduction in mild asthma. Now, we said earlier that the SABA or the short-acting beta-2 agonist is a magic or a wonder drug for them, diba? So for them to use that so often as they needed it, now we try to ask, is the budesonide-formoterol combination, which we will now use for mild asthmatics, be as good as the SABA? Okay, so this study actually looked at that. And they tried comparing formoterol with salbutamol and found out that it works as fast as the salbutamol. O pwede pala eh. It works as fast as that. So it will relieve them of their symptoms as fast as the SABA can. And what's more, it even did better, no? 10 minutes after the reliever, it did better in improving lung function compared with salbutamol and salmeterol. Now, another study that looked at that, again, it showed it's as fast as salbutamol in relieving the symptoms and improving lung function. And in fact, it did better than salmeterol and fluticasone. Now, because of this, now we know that we can use budesonide-formoterol as an anti-inflammatory reliever in asthmatic patients. So this is actually the clinical program that was funded by Astra, investigating the use of budesonide-formoterol as an anti-inflammatory reliever in mild asthma. So we have 4 studies, and it's called Sigma 1 and 2, which is randomized controlled trials. And the novel and the practical are both pragmatic trials, meaning in a real world setting. So Sigma means Symbicort given as needed in mild asthma. So let's try to briefly run through this. The Sigma 1 is a 1-year randomized double-blind parallel group, and they wanted to compare SABA with ICS maintenance plus different SABA in mild asthma. So actually, they have 3 arms. One is, of course, yung gusto natin, the one of interest, no? Is budesonide-formoterol. And they wanted to compare the use of budesonide-formoterol PRN with terbutaline, okay, which is a SABA. And they wanted to know how is it doing compared with a maintenance budesonide, which is supposed to be a controller medicine. Okay, primary efficacy endpoint is well-controlled asthma week. Okay, so they wanted to see the superiority of budesonide-formoterol compared with the terbutaline SABA. Secondary endpoint is looking at also the well-controlled asthma week, meaning they wanted to see the inferiority of budesonide-formoterol compared with a maintenance treatment. Okay. Now, that's Sigma 1. The Sigma 2 is also a 12-month randomized double-blind parallel group study. Okay, this time they only have two arms. So they wanted to know whether budesonide-formoterol PRN is non-inferior to budesonide maintenance with a separate SABA. The primary efficacy endpoint is looking at the annualized severe asthma exacerbation rate. Okay, and the secondary endpoints is lung function. So what did they see? I'll just give you the summary because this is just brief. No, they found out that budesonide-formoterol as needed anti-inflammatory reliever, so PRN lang ang gamit whenever they need it lang. In fact, it is superior to terbutaline as needed monotherapy. And it is similar to low-dose budesonide maintenance BID. Okay? And in reducing the risk of severe exacerbations, budesonide-formoterol, again, PRN anti-inflammatory reliever, is now the recommended strategy for mild asthmatic patients because it also provided substantially lower total inhaled glucocorticosteroid load compared with an ICS maintenance. Of course, no? Kasi ito, you will only use it PRN, pero yung ICS maintenance will be giving you a fixed dose of your inhaled corticosteroids every day. Now, the other conclusion is that in mild asthmatic patients, budesonide-formoterol PRN increased the odds of a well-controlled asthma week. It reduced the rate of severe exacerbations by 64%, and it was able to do that with a more than 75% lower steroid load. Okay, these patients have fewer days of reliever use, and it reduced the short-term risk of exacerbation. Now, we go to the novel and the practical. The novel and the practical, as I said, is real-world study or a pragmatic study that run also for 1 year. Okay? This is just like the Sigma 1. So there were 3 arms also, no? Yung SABA lang, but this time what they used was albuterol and comparing the budesonide-formoterol PRN again with the comparator maintenance budesonide. Okay, they wanted to assess the long-term efficacy and safety of budesonide-formoterol anti-inflammatory reliever compared to SABA as needed or ICS maintenance with a separate SABA. So what did they see? The conclusion is comparing it with albuterol. Albuterol in the Philippines is also known as salbutamol, yung Ventolin natin. No? So comparing it to that, it reduced the rate of exacerbation by 51%, and comparing it with maintenance budesonide, it was similar, okay, in reducing the rate of any exacerbation, and it was able to do that 56% reduction of exacerbation with a more than 70% lower steroid load. Now, what about the practical study? The practical study is similar to the Sigma 2, 1 year, randomized control din siya, open label parallel group. So they also wanted to know the long-term efficacy of budesonide-formoterol anti-inflammatory reliever, comparing it with the maintenance. Okay, so what did they see? Okay, the summary is it reduced the rate of severe exacerbation by how much? By 31%. And again, it lowered the exacerbation with a 42% lower mean daily steroid load. O, di ba? Nice. So, with all those studies, now GINA was convinced that for reasons, GINA no longer recommends SABA only treatment for step 1. So we are not now recommending the use of SABA. And what are those? Albuterol or salbutamol in the Philippines, phenoterol, Yun lang naman. Terbutaline, no? If you still have terbutaline. So GINA no longer recommends that. So for all those who are asthmatics here, don't use the salbutamol only anymore. Okay. Again, this decision was based on the evidences that we have discussed earlier. Okay. And GINA now recommends that all adults and adolescents with asthma should receive ICS containing controlled treatment to reduce the risk of serious exacerbations. Now, let's try to go through the GINA 2020. Let's look at the box at the top first. Okay. So you have here steps 1, 2, 3, 4. And if your patients suffer from this, okay, you don't need to start at step 1. Okay. So if your patient, when you see them, complained of, let's say, symptoms most days, waking with asthma once a week or more, then you can already start at step 3. Okay, let's try to go back to step 1. So step 1 is given to patients who have symptoms less than twice a month. So what's the recommendation? You just have to give them PRN, low dose ICS-formoterol. Okay? As needed for symptoms, low dose ICS-formoterol pa rin. Okay? For step 2, let's say you have that patient and did not improve, then you can step up. So it's stepping up and stepping down. Okay? So you can step up. So now step 2 is if you have initially seen a patient with twice a month or more symptoms, but less than daily, then you can start from here. So the recommendation is to start them on daily low dose corticosteroids, or because of the studies that we have alluded to earlier, you can give as needed low dose ICS-formoterol. Okay. Preferred reliever is the same. Now, step 3, these are the patients who have symptoms most days or waking up with asthma once a week or more. Then you have to combine the ICS LABA low dose and stepping up if they're not controlled. Then you go to medium dose, then you go to high dose. Okay? But here you can see that the preferred reliever in all categories is low dose ICS formoterol. Okay, so that's different from what we have seen in the 2018 guideline. So, how much or how many puffs as needed can we give? Okay, in the GINA guideline, it's 72 micrograms in all, but what we have in the Philippines is the 164.5. So if we will divide the 72 with the 4.5, that's something like 16 puffs. Here, it's 12. Okay, we have other ICS formoterol formulation in the market, and the total daily dose that you can give for those patients on those inhaler is 48 micrograms. Now, this is not a table of equivalence. This is just to show you the suggested total daily doses for the low, medium, and the high inhaled corticosteroids. So you might want to refer to that. Now, let's try to briefly tell you about the Philippine guideline. So for step 1, if for the GINA, it's as needed low dose ICS formoterol, our recommendation is the same. Okay, but for the step 2, there's quite a difference. Okay, so that is the GINA recommendation. The Philippine Consensus Report recommends low dose ICS formoterol PRN or daily low dose ICS formoterol as SMART. MART is maintenance and reliever therapy, or you can give low dose ICS different LABA. Okay. Now, for the step 3, for the GINA, it's low dose ICS LABA. For us, we can already escalate to medium dose ICS LABA or daily medium dose ICS formoterol. Now, for step 4, medium dose for the GINA, to us, it's now the high dose. Okay. And then for the high dose, now it's probably time to refer to a specialist. But mind you, the preferred reliever here will always be the low dose ICS formoterol. Now, let's try to go to COVID and asthma, which is the main topic supposedly. Okay. We all know that it started in Wuhan, China in December, and it spread very quickly worldwide. And then we have known a lot of people died from it. Mortality is very high, it's very infectious. Now, early on, the Chinese CDC in February reported that there are several conditions that are at higher risk for severe COVID. And in fact, chronic respiratory disease was mentioned there. Unfortunately, the chronic respiratory disease was not actually detailed into what kind of respiratory disease is included there. In March 2020, the US CDC also now reported that asthma is there. Okay. So it was listed as one of the conditions associated with COVID-19 hospitalizations. Okay. But recently, we are not seeing asthma as part of the conditions that are at an increased risk for severe COVID. Wala na siya doon, no? And in fact, this is updated, CDC updated September 11, 2020. But, however, no, the conditions that might be at increased risk of severe COVID, asthma is there, but the moderate to severe ones. Okay, so are there actually evidences to say that this is the recommendation? Now, I've tried looking into some studies and came up with this. It's a meta-analysis that looked at the different comorbidities and the mortality risk for asthma. Compared with hypertension, here you can see that they are really at risk. No? Hypertension, CVD, diabetes, COPD, chronic kidney disease, chronic liver disease, congestive heart failure, and cancer. Asthma doesn't seem to be at an increased risk for COVID, severe COVID-19 disease, okay? Much like HIV. Now, we said earlier that asthma is a chronic inflammatory airway disease that would require inhaled corticosteroids. So corticosteroid pa rin siya, okay? And if ever a patient has exacerbation, these patients may require the use of oral or IV corticosteroids, which is a systemic corticosteroid. So now, who actually earlier also did not recommend the use of systemic corticosteroid in non-severe COVID? We all know this, okay? Because of the potential harm. And what is the potential harm? Potential harm is steroids may delay viral clearance, or it may even increase viral shedding. No? That's why they did not recommend it. Now, we all know that very recently, except we can also use oral corticosteroids only in patients who might be requiring that, like exacerbations of asthma or COPD, but we have to give only short courses of oral corticosteroids because of the potential harm. And it was only very recently when the recovery trial came out that they were recommending the use of dexamethasone, but only for severe COVID who will require oxygenation and even the use of mechanical ventilation. So with that, corticosteroid thing, a lot of patients and in fact a lot of clinicians are asking, no, does the pre-morbid or continued use of ICS affect the outcomes of acute respiratory infections because of corona? Are the asthmatics at increased risk of developing COVID-19? Do ICS modify this risk? Do ICS need to be stopped? If they stop it, then they will have exacerbations, no? And all the more these patients will have problems, okay? So there's now a problem whether to stop it because there's problem with the corticosteroid. But on the other hand, these patients will develop exacerbations, okay? Or do the ICS influence the clinical course of COVID-19? So just to remind you that viruses are actually potent triggers of asthma, okay? There's viral-induced exacerbation, and coronavirus is a virus, okay? So in fact, it can really exacerbate any asthmatic patient. And the response of the epithelial cell or the body, no, to viruses, actually, it will produce more cytokines and chemokines, okay? But there is an innate immune problem in asthmatics in that the interferon actually is less in asthmatic patients. And interferons actually is our protection against viral infection. So if there's less interferon to start with and you will have a viral exacerbation, then all the more these patients are at risk for having a severe disease. Now, this is a study that, this is actually an article, no, by Dr. Halpin, and showed us that there are three pathways that a patient with asthma on inhaled corticosteroid may take, okay? So they may be infected with SARS, with COVID, but they may just have mild symptoms or asymptomatic and recover, okay? Some of them may have cough and fever and develop pneumonia, but would still recover. But there are a few who may go into ARDS and suffer death. Now, there are also different results in the use of ICS and among patients with asthma and viral infection and exacerbation. There are reports that ICS use in asthma carries an increased risk of URTI. There are also reports, although not many, that ICS can increase the risk of pneumonia in asthmatics. Or corticosteroids may impair antiviral innate immune response, like the decrease in interferon, and may lead to delayed viral clearance. Or persons with asthma receiving especially high dose ICS are at an increased risk of COVID-related death. Now, however, there are also reports of benefits, like ICS use in patients at risk for ARDS may improve pulmonary physiology and reduce inflammatory markers. Okay. Another study, pre-admission ICS use is associated with reduced risk of direct lung injury or ARDS. And very recently, they have tried looking into pretreatment of human respiratory epithelial cells with budesonide, with glycopyrronium and formoterol, and it has shown to have inhibitory actions on coronavirus replication and cytokine production. And ciclesonide specifically can block SARS-CoV-2 RNA replication and inhibit cytopathic activity. So there are really varied results, and we really actually don't know what the effects actually will be, no? So let me just remind you that this is the SARS virus. Pangit niya, no? Kakainis siya. And it has this spike protein, and it attaches itself to the human ACE2. And before it attaches itself there, it's being primed by the transmembrane protease serine 2, or the TMPRSS2, no? Now, I came up with a study that ICS use actually reduced, okay, the expression of the ACE2, which is distributed throughout the whole of the respiratory tract, no? So dun kasi siya mag-a-attach, right? So it reduced the expression of both the ACE2 and the TMPRSS2, which primes the spike protein to attach to the ACE2. And in fact, this study said the decrease in gene expression for ACE2 and TMPRSS2 provides some assurance that ICS use will not increase the risk of infection with SARS-CoV-2 or morbidity from COVID-19. And this finding should be explored in prospective study. Remember, we don't have a lot of randomized trials now because COVID is just new and there are not a lot of studies on it yet. Okay, so this finding should be explored in prospective studies. But at least that's good news. Okay, and I came up with also systematic review on the use of ICS in COVID-19. And out of the 771 publications, they only reviewed 59 publications, mostly case series, cohorts, and case control, no? So as I said, there are not a lot of RCTs now. Unfortunately, they did not find any data on prior ICS use with COVID-19. There were not even data that has a qualified answer to their question whether pre-morbid use or continuation of ICS is a risk factor for adverse outcomes in COVID-19. There were few studies that reported comorbidities, including asthma and COPD. So generally, there was little or no information about patients' premorbid health or medication. So at present, it is said that that article said that there is no evidence as to whether premorbid use or continued administration of ICS is a factor to adverse or beneficial outcomes in acute respiratory infection due to coronavirus. So RCTs are still needed. There is no evidence to support the withdrawal of the ICS. So we should not be withdrawing the inhaled corticosteroid treatment in our asthmatic patients because doing so may likely be harmful. Okay? So if they're doing well with the ICS, then go ahead. Okay? And then if you have to start a patient, on the other hand, with ICS LABA without you having a clear objective evidence that this is asthma, then don't. Don't start it. And lastly, there is also no evidence to suggest that you have to change your advice to your asthmatic patients that they increase the dose of their ICS during an exacerbation. Okay. So what about oral corticosteroids? So we have talked about inhaled corticosteroids in asthma. What about the oral? I came with two studies, okay? One of which is this one. And let me just try to enlarge it to where the asthma is. Okay. So here you can see that asthma who are asthmatics who are well controlled with no recent OCS use for the past year, which this study was made, no, there is no increased risk for COVID-related death compared with the ones who have used it recently within the 1 year. Okay. And another study um, looking at well-controlled asthma, normal lung function, no exacerbations, and controller treatment on ICS, saying that there is no increased risk for COVID-19 for these patients, compared with those who have impaired lung function, uncontrolled asthma, frequent exacerbations, and oral corticosteroid use, who are at an increased risk for COVID-19. And in fact, probably because of all of these findings, these are all the um, respiratory societies, and in fact, all have given their stand as to the how to use or stand on the recommendation of the use of inhaled or oral corticosteroids. Okay, the GINA, the Gold, European Lung Foundation, American Lung Association, the British Thoracic Society would tell you that they have asthmatics should continue using their inhaled corticosteroids because not doing so may be harmful to them. What about oral corticosteroids? If they need to, they have to be given only with the lowest possible dose in the shortest term. Okay, so most of them will have that recommendation. Also for this, no, Primary Care Respiratory Society, Asthma and Allergy Foundation of America, and even the NICE, no, all of them are saying that asthmatics should continue to use their inhalers. Okay. So the take-home message, one, for this is for COVID-19 and asthma. Well-controlled asthma is not associated with an increased risk of severe COVID. Use of inhaled corticosteroids in subjects with asthma prevents exacerbation, and we have seen that expression of the ACE2 and then TMPRSS2 in the sputum of these patients and should be continued during the COVID-19 pandemic. So I got this actually from Dr. Guy Bruzel from the recently concluded ERS 2020, and he said that the GINA 2020 actually is corona-proof. So just to give you confidence that we are probably doing or we are doing the right thing for our asthmatic patients in this time of the pandemic. Of course, additional recommendations. Spirometry is a no-no now. Know that because it is a very generated treatment. And still until now, we have to avoid the again to the reason that it is very and lastly, we would just like to let you know that there are several studies now that look at the corticosteroids COVID-19. As I said, there are not a lot of randomized controlled trials. So these authors are actually recruiting, patients who might want to join them. There are two, the inhaled corticosteroid and treatment of COVID-19 patients with pneumonia and towards in COVID-19 study. And we await the results of these trials soon in the hope that we would want to give the best to our patients because there's still a lot of things that we need to know about this COVID-19. And I think with that, it's the last slide. Maraming salamat po.
Okay, thank you very much, Dr. Talia, for your lecture. Uh, uh, for the participants, if you wish to ask questions, please use the chat. You can put your questions in the chat so that I can read it for our speaker. Um, if there are any questions from the group, do we have questions from the group?
I have a question.
From
Yes,
Dr.
sir.
Delino.
Dr. Talia, thank you very much. I'm so a little bit late joining, but thank you. Ang question ko, Doctora, is I know it could be a stupid question, no? But what if a patient has presents at the emergency room or at the clinic, the asthma, no? The asthma talaga, no? May asthma po talaga. But at the emergency room, for example, do these patients need to be swabbed for PCR, tested for COVID?
Asthmatic patients that go to the ER?
Yes.
Yeah, why not? Especially if you have the suspicion that this may be COVID.
Mm.
It doesn't differentiate them from any other patient.
Okay.
Oo.
No, is there of course it depends on the clinical diagnosis, but for example, if is it routine na lang pala? Yun na lang ang question ko, Doktora. Would it be safer to swab routinely PCR for patients who clearly are having an asthmatic exacerbation, but but should it be done routinely
Ah,
or selectively pa rin?
depende yan sa symptoms, no? As I said earlier, if you are highly considering COVID, let's say this patient complained of fever, of cough, dyspnea. Okay? So this may also be a sign of an asthmatic patient that may have a viral infection early on. So,
Okay.
diba?
Yeah.
One day fever may still speak of a viral infection. If you are highly considering and you do not know whether this is just an exacerbation or a COVID infection, then you might as well get the swab. Okay? Again, the timing will be very important. Okay, so if this patient actually had cough for, let's say, 2 weeks,
Mm.
went to the emergency room, and the only time that you will swab the patient, you
Yes.
might get negative results, diba? Because
Yes.
we know that the highest yield for the swab test is during the first 3 days, first 2 days pre-symptom, and then first 3 days, diba?
Mm-hmm.
So if it's beyond the timing where you get the highest yield, then you may not be able to get the right result that you want to get. So malilito ka na. COVID ba talaga siya na nag-negative lang kasi mali ang timing mo? Or talagang hindi siya COVID? So again, the timing of getting the swab is very important.
All right. Yeah. Yeah.
It
Thank
should
you.
not be routine, okay? It should not be routine, but if you highly suspect, then go ahead.
Okay. And then continuing with that specific case, Doctora. So you don't know anymore, no, because it's COVID, whether it's COVID or not, and then it would seem that the doing a swab is pointless because it might turn out negative, but the patient has COVID anyway. So what do we do with that? We proceed with a battery of tests for COVID, like a CT scan or a chest CT or something.
Yeah, that might help also. So remember, if the patient complains of dyspnea and this turns out to be now COVID positive, So lalo na kung exacerbate, and if your history will show that this asthmatic patient has uncontrolled asthma, di ba? We said earlier that an uncontrolled asthmatic may be at an increased risk.
Mhm.
You might want to go through and the same treatment like a COVID patient.
Okay.
Ganun na. The recommendation for what we need to do for a COVID patient, then we need
Okay.
to do all those. Okay. If,
Yeah.
if your RALs on PE
Mm.
and the X-ray would show pneumonia, you might want to do CT scan, no?
Mm.
Ganun. And then all the battery of tests, looking at now whether this patient is at risk for cytokine storm. So depending on the inflammatory markers the results of the inflammatory markers that you might have.
Okay. Thank you, Doctor. Next question, Doctor, but it's not clinical anymore. But in your experience, I'm just very curious. In your experience in the other institutions that you practice in, for these patients who's who's the clinical course looks like they're COVID, but they're not COVID, no? But you don't have a positive COVID test, no? Would PhilHealth would PhilHealth cover for these patients in your other institutions?
Negative COVID,
Yeah, but
but the course COVID-like.
yes.
Mahirap yan. Kasi, alam mo lang, PhilHealth, one track mind yan eh.
Yeah,
You
yeah.
have to convince them that you really have a positive result.
Mm.
I don't know, maybe we can justify that, but it's a long process that you have to convince PhilHealth, COVID yan because of this. Pero nasan yung result mo? Wala
Yeah.
kang makita. So it might be a little difficult for
Mm.
PhilHealth to consider that.
Yeah.
We can because of all the paperworks that would show that this is really severe infection
Pneumonia. Yeah.
COVID that turned out to be negative, or you might want to repeat the test, no? Pwede namang
Okay.
ulitin yung swab test until we get a positive result, no? Kung
Yeah.
talagang negative, yun yung mahirap.
Mhm.
Mahirap kumbinsihin yung PhilHealth na sarado ang utak sa pagbigay ng pera sa ospital. Diba? So,
Okay.
that's
Yeah.
the downside of that.
Thank you, Doctor. Thank you.
You're welcome.
Okay, thank you, Dr. Galido.
Personally, no, there are not a lot of asthmatic patients except for Rina right now. Our nurse, no, but we still don't know the result. She had the swab, but she's the only asthmatic patient that I have right now that was hospitalized. Hopefully, it's not COVID, but she's okay now. She doesn't have difficult breathing naman, no, and the X-ray is normal. So, wala. Parang baka nga, no, looking back, these asthmatic patients might actually be protected. So, we await the results of some of the trials that are being done now.
Okay. Any other questions from our group? While there's none yet, I would like to ask Dr. Talla. In the management of moderate to severe COVID, we use IV dexamethasone. So
Yes.
if incidentally our patient is also asthmatic, can we use just dexamethasone as our anti-inflammatory for the asthmatic, or do we use another steroid?
Actually, there are several recommendations, di ba? You can either use dexamethasone, you can either use prednisone, methylprednisolone, prednisolone. So you have choices. Okay, so in an
Yeah.
asthmatic patient where you have to use IV steroids, the equivalent of dexamethasone 6 milligrams, 40 milligrams of prednisone, 10 milligrams of methylprednisolone every 6 hours, or Solucortef or hydrocortisone 100 milligrams Q8. Okay,
Yes.
so those are the equivalent steroids that you can use. So it's not only dexamethasone. Okay, if you don't like to use dexamethasone, you want to use the short-acting steroids, you can use Solucortef. You want to use Tolumedrol? Yes, you can go ahead and use that. You want to use oral prednisone? Fine. Okay, nagkataon lang that what was used in the recovery trial is dexamethasone.
Okay. Oh, so there's still no questions in the chat.
I have a
One more
question.
question?
Question.
Yes.
Doktora,
Kaya mo pala ako pinag-lecture eh.
Doktora?
Kaya mo pala ako pinag-lecture eh. Then, go
Ah,
ahead.
yeah. This one slide I got interested on yung cyclosinide ba yon, Doktora? That you said it, yeah, it could be protective
Yes.
for COVID. What's up with that, Doctor? Are they really pursuing that, studying that drug?
I think so. There are initial studies on that, but they are doing more. Not only cyclosinide, but you saw in another slide, there are now uses. They're using budesonide, which is also a corticosteroid, with glycopyrronium and formoterol also. So we'd like to know more about this in the future. There are not a lot of studies around because, coronavirus is just, COVID-19 is just evolving, and we are actually looking forward to all of these studies. There are some really parang potential benefits on its use. But until now that we have hard evidence on that, wala pa. So these are just initial studies that gave a beneficial outcome. So we still don't know. We need more studies to have evidences on it.
Doktora, isa pang question. Yeah, I also had asthma when I was a child during my teenage years. I really had severe exacerbations. But then that was about 30 years ago, 30 plus years ago. Then I was given prescribed budesonide. Budecort pa noon, Doktora. Budecort, turbo haler.
Oh, matanda
So
na.
and then wow, it's like a miracle. Hindi na ako inaatake and ever since, no. Do you get cured? My question is, do you ever get cured? I mean, like me, can I consider myself cured
No.
of asthma?
Of course not. Once an asthmatic, you will remain to be an asthmatic for the rest of your life.
Oh,
Okay.
okay.
Just that it's not being triggered. Seems like you have some other iba-ibang phenotypes ng asthma eh. So you're not the type that will not have any frequent exacerbations. Okay. But it doesn't mean that you will not have it. You can still have it later in life. Especially so if there's something that triggered that. Okay? So ganun yun. So don't ever think you're not an asthmatic. What I was telling you earlier, di ba? An asthmatic patient will always have inflammation there, whether or not they have symptoms.
Okay. All right.
But
it was just like miracle, Doctor. It's just like a miracle. Talagang wow. Parang you the beauty court na yan. Oh.
Baka you have outgrown the triggers of asthma.
Okay. Thank you po.
Thank you, Dr. Galido. Well, it's already 6 o'clock. There is another webinar coming up at 6 o'clock. So, well, since there aren't any other questions, we would like to ask Dr. Galido for closing remarks.
Yeah,
thank you, Malen.
Po.
One last. Ang question ko sa'yo, how do you really say your surname? Is it Galido, Helido, Gelido? Nalilito ka.
It's Galido na lang po. Galido. Oh.
Okay, thank you.
Opo. Thank you. Doctor, do you still need to, I think our friends from AstraZeneca talked to me. We talked earlier. Are you still going to present something? Doctora?
Are you there? Me? No. I already presented the evidences.
All right. So,
are you here, Ariel?
Yeah, Ariel.
Yes, Doc.
So Ariel, yeah, we talked earlier, no? So, is Doctora still supposed to deliver a presentation?
No, Doctor, okay na po yun.
Okay na.
Opo, yung Budesonide-Formoterol naman, it's still on the GINA Guidelines 2020, yung ating bagong guidelines. So, that would be well, Doctor, for the management of asthma. Yun lang naman po yung message na gusto namin maparating to all the doctors. Not necessarily to brag the specific product, of course, para makatulong din sa mga patients and to the doctors, yung bagong knowledge natin. Thank you, Doctor. Thank you, Doctor.
Thank you. And
thank you, Dr. Manen.
Ay, salamat, Ariel. Yeah. And so it's already 6 o'clock or 6:01 na. Now, thank you everyone for attending this session. This this was our third. This is our third webinar, monthly webinar, and we had the first one about COVID, and then we had hemoperfusion, and now thank you to Dr. Cynthia Talla for updates on COVID, asthma, no, primarily asthma, and then asthma plus COVID, and so yun pa rin, no, and yeah. I guess that's it, and we will wait for more for volunteers for this month of October, end of October, for whoever wants to present and share their expertise to the St. Francis Cabrini community and even beyond it, for so that we can learn from your experience and your expertise. Thank you very much, everyone. Thank you very much to the consultant, physicians, to the nurses and other staff who've attended. I hope you learned and you were updated on your knowledge regarding asthma and how asthma relates to COVID, especially nowadays. Thank you very much, Dr. Talia. Thank you very much, everyone. Have a good evening.
Thank you,
Bye.
Doc.
Goodbye.